The author does not have any financial interest in this video. Bullous keratopathy is a commonly encountered pathology in the OPD. Less frequently, the patient presents in early stage with no stromal scarring, good view of antechamber, and normal functioning pupil. Rather, more commonly, they present either with stromal scarring obscuring the view of antechamber, eccentric pupil, atrophic iris, fixed dilated pupil, subluxated IOL, or either combination of above. So, this is a case of 65-year-old male diagnosed with left eye pseudophakic bullous keratopathy having a visual acuity of counting finger at 2 meters. The patient had a poor view of antechamber, associated peripheral anti-synechiae from 3 o'clock to 9 o'clock hour, and fixed mid-dilated pupil. The patient was planned for descemet membrane endothelial keratoplasty. Epithelial stripping is performed using scraper to improve the view of antechamber. Centration is marked and 7 mm marking is done using caliper. Corneal incision using 2.8 mm keratome is made. Viscoelastic is injected to inflate the antechamber. Iris repositor is used to break the anterior synechiae. Maneuvering of the instrument to break the synechiae is done in such a way so that there is minimal stretch at the root of the iris so as to prevent iridodialysis and bleeding from the angles. Gentle stripping of the iris repositor is done at the angles to break the peripheral anterior synechiae. A transparent membranous structure with pigment deposits is noted, which is attached to the iris and is identified as detached descemet membrane. Stripping of the detached descemet membrane is done. Remnants of the descemet membrane are removed using Utrata forceps. Still, there is some descemet membrane attached to the iris which is cleaved using the Vanna scissor. The remnant descemet membrane is removed using the forceps. Visco wash is performed. .2% pilocarpine is injected to bring down the pupil size. One can notice that there is some descemet membrane still attached at the pupillary margin. An attempt is made to strip the remnant descemet membrane attached at the pupillary margin. However, it fails to separate. 20 gauge cutter is used to nibble the edges of descemet membrane which is attached at the pupillary margin. It is important because it may hinder the DMEK graft unfolding. Care is taken not to damage the sphincter. Peripheral iridotomy is made at 6 o'clock using the cutter. Visco wash is performed. A standard protocol is followed to make a 7 mm DMEK graft. Graft is then loaded using the injector prepared from the IL cartridge. Gentle taps are made using 27 gauge cannula to unfold the graft in correct orientation and center it. Intermittently, the antechamber is shallowed to prevent the re-scrolling of the graft. After ensuring the correct orientation and centration, air is injected in the antechamber to fix the graft. Antibiotic drops are instilled and BCL is applied. On post-op day 1, the graft appeared to be well attached as confirmed on AIOC2024. At 1 week post-op, the cornea appeared clear and compact and vision improved to 20/60. Since every case of pseudophakic bullous keratopathy is unique in its own way, a careful pre-op planning is needed. In chronic cases of bullous keratopathy, the maneuvering inside the antechamber should be as gentle as possible to avoid antechamber bleeding, which can make the surgery more challenging. Also, it is imperative to counsel the patient regarding the expectations and the outcomes of surgery for better compliance with the postoperative care.